This is Kathy Knipper, instructor for Nursing 2203, recording the Pediatric lecture for Chapter 46, Endocrine Dysfunction. Let's talk about a little refresher on the endocrine system. The cells send chemical messages by means of hormones. The target cells, or the end organs, receive the chemical messages, and the chemicals are transported through the blood, lymph, and extracellular fluid. And remember that hormones are complex chemical substances. This diagram includes the hormones as well as the target organs. Disorders of pituitary function. These disorders may be due to organic defects or have an idiopathic cause. The problem may involve a single hormone or a combination of several hormonal deficiencies. Clinical manifestations depend upon the hormone involved. The disorder may result in an overproduction or a hormone deficiency. When we talk about hypopituitarism, we will focus on growth hormone deficiency. But overall, there's more than one hormone that's produced by the pituitary. Of course, with growth hormone deficiency, that means that the secretions are deficient of the growth hormone. Consequences depend upon the degree of dysfunction. To diagnose a growth hormone deficiency, we would look at the family history. We would assess growth patterns and previous health status, complete a physical examination as well as a psychosocial evaluation. A radiographic survey would be important, and also endocrine studies would be performed. For therapeutic management of growth hormone deficiency, treatment is directed toward correcting the underlying disease process. Replacement with growth hormone is successful in 80% of affected children. This therapy is ended when growth rates are less than 1 inch per year. For girls, that would be at 14 years of age, and for boys, it would be at 16 years of age. Nursing care for the child with a growth hormone deficiency includes identifying and assisting with the diagnosis, providing child and family support, assisting with the emotional adjustment of the child. The child's abilities and strengths should be emphasized instead of physical size. They should have the same age-appropriate responsibilities. The nurse also helps with preparation for testing and medication administration and provides increased attention to the child during testing. With pituitary hyperfunction, excess growth hormone before closure of the epiphyseal shafts results in overgrowth of the long bones. Patients can reach heights of 8 feet or more. Vertical growth is accompanied by increased muscle. The weight is generally in proportion to height. Acromegaly is caused by pituitary hyperfunction. The excess growth hormone after the epiphyseal closure is called acromegaly. Typically, several facial features undergo overgrowth: the head, lips, tongue, jaw, and nose, paranasal, mastoid sinuses, and then there's separation and malocclusion of the teeth. Diagnostic evaluation of pituitary hyperfunction involves identifying a history of excessive growth during childhood, evidence of increased levels of growth hormone, radiographic studies that may reveal a tumor, and then endocrine studies. There would be an increased level of growth hormone and other hormones such as thyroid, cortisol, and sex hormones. Therapeutic management of pituitary hyperfunction would include surgical treatment if there's a tumor, so the tumor would be removed. Radiation and radioactive implants are used. Also, hormone replacement therapy may be used after surgery. They might include thyroid extract, cortisone, and sex hormones. Care management of the child with pituitary hyperfunction. This would involve early identification of children with excessive growth rates, early treatment for improved outcomes, observation for signs of tumors such as headache, increased hormone levels, providing emotional support, as well as addressing body image concerns. Precocious puberty is defined as sexual development before age 9 in boys and before age 8 in girls. Evaluation for a pathologic cause is required in white girls younger than 7 and African American girls younger than 6. This may be caused by disorders of gonads, adrenal glands, the hypothalamus or pituitary gland. It affects the testosterone level in boys. FSH and LH levels in girls lead to premature secretion of estrogen by the ovarian follicles. Box 46-4 on page 1465 identifies very specific causes of precocious puberty. Treatment is directed toward the specific cause, if it's known. Types of precocious puberty. Central precocious puberty, or CPP, occurs in 80% of the cases. It involves early maturation and development of gonads and secondary sex characteristics. It involves the hypothalamus. Peripheral precocious puberty involves premature development of breast, pubic, and axillary hair and menses. It involves other sources of hormone stimulation, such as gonads and adrenal glands. Therapeutic management of precocious puberty. As stated previously, the specific cause would be treated if it is known. It may also be treated with leuprolide or Lupron. This slows prepubertal growth to normal rates. Treatment is discontinued at the age when normal pubertal changes are expected to resume. Psychological support for the child and family is important. Diabetes insipidus is the principal disorder of the posterior pituitary gland. It results from hyposecretion of antidiuretic hormone, also called ADH. It produces uncontrolled diuresis. The primary causes are familial or idiopathic. Secondary causes include trauma, tumors, central nervous system infection, and aneurysm. The cardinal signs of diabetes insipidus are polyuria and polydipsia. Infants exhibit irritability that is relieved with feedings of water. Dehydration often occurs. Diabetes insipidus is diagnosed by reducing fluid intake with little or no effect on the urine output. Therapeutic management of diabetes insipidus. The nurse should instruct parents in the difference between diabetes insipidus and diabetes mellitus. It requires daily hormone replacement. The drug of choice is vasopressin, or DDAVP. It can be administered through a nasal spray or IV. It can also be given through a subcutaneous or intramuscular injection. Treatment is required for life. Syndrome of inappropriate antidiuretic hormone, or SIADH, results from oversecretion by the posterior pituitary gland, which results in increased ADH. It leads to fluid retention and hypotonicity. Symptoms include anorexia, nausea and vomiting, irritability, and personality changes. Symptoms are alleviated when ADH is decreased. Care management of SIADH. The nurse should accurately measure intake and output, observe for signs of fluid overload, take seizure precautions, administer ADH antagonizing medications, and provide child and family education. Disorders of thyroid function. The thyroid hormone regulates basal metabolic rate. The thyroid gland secretes two types of hormones: the thyroid hormone, which is made up of thyroxine or T4, and triiodothyronine, which is T3. It also secretes calcitonin. Patients may have hypothyroidism or hyperthyroidism, and they may have disturbances in the secretion of thyroid stimulating hormone, or TSH. Juvenile hypothyroidism may be congenital due to congenital hypoplastic thyroid gland or acquired, and this can be caused by a partial or complete thyroidectomy for cancer or thyrotoxicosis. It could occur after radiation therapy for Hodgkin lymphoma or other malignancies. This rarely occurs from a dietary insufficiency of iodine in the United States because of the use of iodized salt. Clinical manifestations of juvenile hypothyroidism include mental decline, constipation, sleepiness, myxedematous skin changes such as dry skin, sparse hair, and puffiness around the eyes. Therapeutic management of juvenile hypothyroidism includes oral thyroid hormone replacement. Prompt treatment is needed for brain growth in the infant. It may be administered in increasing amounts over 4 to 8 weeks to avoid symptoms of hyperthyroidism. Compliance with the medication regimen is crucial. Goiter is a hypertrophy of the thyroid gland. It may occur with deficient, excessive, or normal thyroid hormone secretion. If it's congenital, it usually results from maternal ingestion of antithyroid drugs during pregnancy. If it's acquired, it results from a neoplasm, inflammatory disease, dietary deficiency, but that's rare in children, or an increased secretion of pituitary thyroid stimulating hormone, or TSH. Goiters may become noticeable during periods of rapid growth. Large goiters may be obvious. Smaller nodules may be evident only on palpation. Thyroid hormone replacement is necessary for treatment of hypothyroidism. Immediate surgery may be life-saving in infants born with goiter. Lymphocytic thyroiditis is also known as Hashimoto disease or autoimmune thyroiditis. It is the most common cause of thyroid disease in children and teenagers. It occurs most frequently after the age of 6 and it peaks during adolescence. Clinical manifestations of lymphocytic thyroiditis include an enlarged thyroid gland, which is usually symmetrical, firm and non-tender, and freely movable. Another manifestation is tracheal compression. There's a sense of fullness as well as hoarseness and dysphagia. Hyperthyroidism is possible. Therapeutic management of lymphocytic thyroiditis. The goiter may be transient and asymptomatic. It may resolve spontaneously within 1 to 2 years. Oral thyroid hormone administration often decreases the goiter significantly. Surgery is contraindicated in this disorder. Hyperthyroidism and Graves' disease. Graves' disease constitutes the largest percentage of cases of childhood hyperthyroidism. It is believed to be caused by an autoimmune response to TSH receptors. Diagnosis is based on increased T3 and T4 levels. TSH is suppressed to unmeasurable levels. Signs include an enlarged thyroid gland and exophthalmos. The incidence peaks between the ages of 12 and 14, but the condition may be present at birth. A familial association exists. Manifestations include such things as tachycardia, widened pulse pressure, exophthalmos, and weight loss. Refer to box 46-7 on page 1469 for more. Management of Graves' disease. The therapy is controversial, but the goal of therapy is to retard the rate of hormone secretions. Treatments may include antithyroid drugs, subtotal thyroidectomy, and ablation with radioiodine. Thyrotoxicosis, also known as thyroid crisis or thyroid storm, may occur from the sudden release of thyroid hormone. It is unusual in children, but it can be life-threatening. It may be precipitated by infection, surgery, or the discontinuation of antithyroid therapy. Signs and symptoms include severe irritability and restlessness, vomiting, diarrhea, hyperthermia, hypertension, severe tachycardia, and prostration. Treatment of thyroid storm includes antithyroid drugs and propranolol. Disorders of parathyroid function. As you know, parathyroid glands secrete parathormone, or PTH. The function of parathormone, or PTH, is to maintain serum calcium levels by increasing release of calcium and phosphate from bone demineralization, increasing absorption of calcium and excretion of phosphate by the kidneys, and promoting calcium absorption in the GI tract. Hypoparathyroidism may be caused by a specific defect in the synthesis of PTH. It also may occur secondary to other conditions, such as infection and autoimmune syndromes. It may occur postoperatively after thyroidectomy. It may occur with conditions during the neonatal period, such as maternal hyperparathyroidism or maternal diabetes mellitus. Also, it may occur because of formula with high phosphate to calcium ratio. The clinical manifestations of hypoparathyroidism include dry, scaly skin with eruptions, brittle hair, thin nails with transverse grooves, tetany, paresthesias, tingling, laryngeal stridor, spasms, or a combination of these, headache, seizures, emotional lability, depression, confusion, and memory loss. You can refer to Box 46-8 on 1471 for more. Now let's discuss hyperparathyroidism. Primary hyperparathyroidism may be due to an adenoma of the gland. The secondary form may be due to chronic renal disease or congenital anomalies of the urinary tract. A common factor is hypercalcemia. This condition is rare in children. Refer to Box 46-9 on page 1471 for clinical manifestations such as nausea, vomiting, delusions, confusion, weakness, bone pain, and fractures. Hyperparathyroidism. Diagnostic evaluation involves blood studies to identify increased calcium and decreased phosphorus levels. Therapeutic management includes surgical removal or treating the underlying cause if that's possible. Care management would involve recognizing the disorder so that early treatment could occur. Disorders of adrenal function. As you know, the adrenal cortex secretes three groups of steroids: glucocorticoids, such as cortisol and corticosterone; mineralocorticoids, such as aldosterone; sex steroids, such as androgens, estrogens, and progestins. Altered levels of these produce significant dysfunction. Disorders of adrenal function. The adrenal medulla secretes catecholamines, such as epinephrine and norepinephrine. Catecholamine secreting tumors are the primary cause of adrenal medullary hyperfunction. An acute adrenocortical insufficiency is also called adrenal crisis. Etiologic factors include hemorrhage into the gland from trauma, fulminating infections, abrupt withdrawal of exogenous cortisone, failure to increase cortisone during times of stress. Diagnosis is generally based on the clinical symptoms. Clinical symptoms of acute adrenocortical insufficiency include increased irritability and headache, abdominal pain, nausea, vomiting, diarrhea, and weakness. See Box 46-10 on page 1472 for additional manifestations. Diagnosis is based on the clinical presentation. Therapeutic management includes replacement of the cortisol, fluid, glucose, and possible antibiotics. Improvement after cortisol replacement confirms the diagnosis. This condition is potentially fatal. It would be important to monitor vital signs, blood pressure, take seizure precautions related to an elevated temperature, and so on. Chronic adrenocortical insufficiency, or Addison disease. This is rare in children. It may be caused by infections, neoplasms, autoimmune processes, or it may be idiopathic. The symptoms appear gradually after 90% of the adrenal tissue is non-functional. Chronic adrenocortical insufficiency, or Addison disease, is diagnosed through measurement of functional cortisol reserve. The therapeutic management includes replacement of cortisol, or glucocorticoid, and aldosterone, the mineralocorticoid. These individuals need more cortisol with stress, such as fever, infection, emotional upset, and surgery. The dosage must be tripled to accommodate the body's increased need for glucocorticoid. If they get too much, they may develop Cushingoid signs. Care management includes parental guidance and education on items like the signs and symptoms of insufficiency, the importance of keeping a spare supply of cortisol injections for an emergency, and medication side effects. Cushing syndrome is a characteristic group of manifestations caused by excessive circulating free cortisol. There can be a variety of causes. It may be caused by excessive or prolonged steroid therapy. This condition is reversible once the steroids are discontinued. An abrupt withdrawal of steroids, as you know, may precipitate acute adrenal insufficiency. You might look at figure 46-2 in your med-surg textbook. So what would a Cushingoid appearance look like? You would see excessive hair growth, moon face, red cheeks, weight gain, pendulous abdomen with red striae, poor wound healing, and ecchymoses. This picture demonstrates the characteristics of Cushing syndrome. Diagnostic evaluation of Cushing disease includes measurement of serum cortisol levels, imaging of the pituitary and adrenal glands, skull films to check for enlargement of the sella turcica, dexamethasone suppression test where the ACTH remains elevated, and other laboratory tests such as fasting blood glucose levels, serum electrolyte levels, and 24-hour urine collections. Therapeutic management of Cushing disease depends upon the cause. Usually it's surgical intervention through a bilateral adrenalectomy with hormone replacement therapy. If it's a pituitary tumor that's been surgically treated and irradiated, growth hormone, ADH, thyroid hormone, gonadotropins, and steroids will need to be replaced. Care management includes administering steroids in the early morning with an alternate day schedule. Postoperatively, for an adrenalectomy, you would observe for shock-like symptoms. You would look for hypotension, hyperpyrexia. You would give post-op teaching related to the hormone replacement, signs and symptoms to expect, and then give psychological support. Congenital adrenal hyperplasia. This condition occurs in 1 per 12,000 to 15,000 births. It is an overproduction of cortisol precursors and adrenal androgens. This is in response to decreased enzyme activity necessary for cortisol production in the adrenal cortex. The androgens cause masculinization. You would see varying degrees of ambiguous genitalia. A salt wasting crisis frequently occurs in the first few weeks of life. They fail to gain weight, have hyponatremia and hyperkalemia, and there is a possibility of cardiac arrest. Therapeutic management of congenital adrenal hyperplasia. You would administer glucocorticoids to suppress ACTH and diagnose and assign a sex to the child according to the genotype. Reconstructive surgery may be required. Not all cases are diagnosed at birth, and this is an autosomal recessive disorder. A pheochromocytoma is an adrenal tumor that secretes catecholamines. It may occur around the adrenal medulla, along the paraganglia of the aorta, or along the thoracolumbar sympathetic chain. The tumors are often bilateral, multiple, and benign. Clinical manifestations are the result of the increased production of catecholamines. So you would see hypertension, tachycardia, headache, decreased GI activity with constipation, increased metabolism with anorexia, weight loss, hyperglycemia, polyuria, polydipsia, hyperventilation, nervousness, heat intolerance and diaphoresis, and possible signs of CHF. Therapeutic management of pheochromocytoma involves surgical removal of the tumor or tumors. It may require bilateral adrenalectomy and lifelong glucocorticoid and mineralocorticoid therapy. Care management involves identification of the condition. These symptoms can be confusing. They may indicate a psychological cause. Hypertension is an outstanding clue. It would be important to not palpate the mass because that could stimulate release of catecholamines that can lead to hypertension and tachydysrhythmias. Disorders of pancreatic hormone secretion. Diabetes mellitus. This is characterized by a total or partial deficiency of the hormone insulin. This is the most common endocrine disorder of childhood. The peak incidence occurs between the ages of 10 and 15 years of age. There's an increased risk for African American and Hispanic children. Type 1 diabetes mellitus is characterized by destruction of beta cells, usually leading to an absolute insulin deficiency. The onset is typically in childhood and adolescence, but it can occur at any age. Most childhood cases of diabetes mellitus are type 1. This is more prominent in white people. Refer to Table 46-1 on page 1477. Type 2 diabetes mellitus arises because of insulin resistance. The onset is usually after age 45. Native American, Hispanic, and African American children are at increased risk for type 2 diabetes mellitus. Affected people may require insulin injections. See Table 46-1 on page 1477. Pathophysiology of diabetes mellitus. With a deficiency of insulin, glucose is unable to enter the cell and remains in the blood. This causes hyperglycemia. When the serum glucose level exceeds the renal threshold, glucose spills into the urine. This is termed glycosuria. Cells break down protein for conversion to glucose by the liver, glucogenesis. This contributes to the hyperglycemia. Ketoacidosis. When glucose is unavailable for cellular metabolism, the body breaks down alternative sources of energy. Ketones are released and excess ketones are eliminated in the urine, termed ketonuria, or by the lungs, acetone breath. Ketones in the blood are strong acids that lower the serum pH and produce ketoacidosis. Diabetic ketoacidosis is a pediatric emergency. It results from progressive deterioration with dehydration, electrolyte imbalance, acidosis, coma, and possible death. Therapy should be instituted in an intensive care unit setting. It involves insulin therapy, correction of the fluid and electrolyte imbalances, especially potassium. Also, the nurse would measure and weigh the child and place the child on a cardiac monitor and obtain samples for lab work. Long-term complications of diabetes mellitus, as you know, can be microvascular, especially nephropathy and retinopathy with the kidneys and the eyes, macrovascular disease, neuropathy. If control is poor, vascular changes can occur as early as 2.5 to 3 years after diagnosis. With excellent control, these changes can be delayed for 20 years. It would be important to take a multidisciplinary approach when managing type 1 diabetes mellitus in children. It would require insulin therapy, usually by injections 2 times per day. A pump may be used. Requires glucose monitoring with the goal to be near normal levels of less than 126 milligrams per deciliter. It requires measuring glycosylated hemoglobin or hemoglobin A1C. It requires glucose control to decrease the risk of long-term complications and selection of appropriate insulin preparations. Therapeutic management of type 1 diabetes mellitus includes proper nutrition and exercise, the morning measurement for hyperglycemia, illness management to restore normal glucose levels, treat urinary ketones, and maintain hydration. So with illness, you would monitor glucose and ketones every 3 hours. You would also administer fluids to prevent dehydration and flush out ketones. Other management would include managing the diabetic ketoacidosis and fluid and electrolyte therapy. When you teach the patient and family, you would teach them about the nature of the disease, meal planning, traveling, insulin therapy. Usually the injections are twice daily and they're subcutaneous. They may use a pump. You would go over the injection procedure. You would also teach about continuous subcutaneous insulin infusion if that's being used with the patient. You would teach them how to monitor glucose. Other content that should be taught to the patient with diabetes mellitus is how to recognize and treat hypoglycemia and hyperglycemia, how to manage minor illnesses, how to keep records, how to exercise appropriately, proper hygiene, self-management, and how to maintain that support of the entire family.